Good afternoon and welcome to HIT Policy Update with Dr. John Halamka, a webinar tweet chat combo from healthsystemcio.com sponsored by OnBase by Hyland. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of healthsystemcio.com, and I will be your webinar moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can view the tweet chat in the Media Viewer panel on the right-hand side of your screen. Other WebEx panels we're going to use today are the Q&A panel. You can submit your questions at any time in the lower right-hand corner of your screen and keep the default set to all panelists. We will take those later in the program, but go ahead and send them in as they occur to you. And you can download the deck for today's event. The URL is on your screen. It's at the bottom of some of our slides and will be sent out in the chat box. Just so you see how we're going to spend our time today, first we're going to hear from our featured speaker, Dr. John Halamka, CIO at Beth Israel Deaconess Medical Center. And then we're going to hear from our sponsor, represented by Lorna Green, Manager of Global Healthcare with OnBase by Hyland. And then we're going to have our Q&A. So without further delay, I'm going to turn it over to Dr. John Halamka. Thanks for joining us today.
Well, thanks so much. Always a joy to speak with you guys. These days, I'm spending much of my time in international service trying to take the lessons of the high-tech era and help the UK and various spots in Asia and Africa. But while helping these international communities, it's really important that we continue to make great progress in the United States. And so when we get together quarterly, it's interesting to reflect on what is the role of government, what is the role of the private sector, what are the major policy enablers and barriers. And so what I've done for this particular webinar is put together the list of the things that have happened over the last 90 days that hopefully will affect your decision making and give you clarity as you move forward to support your providers and your staff and your patients. So our agenda today, we'll be looking at, well, what is ONC up to? What are they thinking? What is likely over the next year to two to be ONC's agenda? We'll take a look at what has been coming out of not only HHS, but other departments in the Trump administration and how those might affect your IT strategic planning and budgeting. And then I'll reflect on what is, based on the trends that we're seeing in those first two agenda items, what is the federal government's role going forward and what can we expect? And it's very important, especially we are given various mandates and deadlines for compliance, to ask, should those be our focus or should we begin to focus more on our customers and our patients and the strategic imperatives we have from our management team? So we'll reflect on that. Then I'd like to end with what are some of those industry trends that I think are real? Because every day you hear about the entrepreneur who creates the cloud-hosted blockchain artificial intelligence machine learning mobile application, and you say, really? So what's real and what's not? Oh, Anthony, you bought one of those too.
Absolutely.
Okay. So Don Rucker, as we talked about the last time, our new national coordinator, was a Beth Israel Deaconess physician for 10 years. Internist as well as a formally trained informatician. And his approach is slightly different from that of previous national coordinators. And that is, I would say, he doesn't have an activist regulatory agenda with a set of a rank-ordered list of items from stakeholders and a multidisciplinary suggestion of what to do. What he's looking to is the bipartisan 21st Century Cures legislation, and feels that, well, that was something that we had both sides of the aisle come together on, so let's focus on implementation of 21st Century Cures. And so rather than coming up with meaningful use stage 5 or coming up with a set of novel requirements, it's implementation of what 21st Century Cures tells us to do. And what are the kinds of things you find in 21st Century Cures? So you find increased emphasis on interoperability, and I know interoperability is a somewhat vague term, but the idea in 21st Century Cures is that with appropriate patient consent and potentially patient facilitation, certain data elements could be transferred to certain stakeholders to improve clinical trials, clinical research, and maybe even population health or care management, the next generation of figuring out how to keep you healthy based on the experience of other patients like you. So interoperability isn't going to mean that 100% of the medical record is exchanged with every person in real time for every purpose at no cost. It's going to mean specific use cases will be supported with novel models, and 21st Century Cures, among other things, does highlight the notion of the patient as the facilitator of data exchange. And you could understand how that would be interesting, that we know we have 50 sets of state laws, all of which preempt HIPAA, and therefore we have 50 sets of privacy and consent policies. But the Office of Civil Rights has told us that if a patient moves their data around, then there's really no issue with any covered entity ever being held accountable for inappropriate use of data. So that's where 21st Century Cures envisions a day where the patient's health record and those salient elements that might be needed for drug discovery or might be needed for novel applications of molecules are moved around by the patient. And they're done so with an application program interface that enables the patient on their phone or wherever to pull the data that's necessary and then push it to a next consumer of that data, all with appropriate patient consent. So watch for ONC supporting initiatives, especially around consumer use of data and open APIs, the idea that data can flow not with just an HL7 transaction or a CCDA document, but that it actually can be pulled as structured data out of the electronic health record by novel applications that a patient may be running on their mobile device. Also, you're going to see an emphasis on usability. Now remember, in the high-tech era, many things changed quite fast. Quality metrics were added and new workflows, and often our electronic health record vendors did not have time to engineer highly usable solutions. If you have a final rule issued and then 18 months later, every one of your customers has to be running the code that instantiates that rule, you just don't have a lot of time for iterative improvement. So what you saw was our EHR vendors did their best, but it was also often grafting novel workflows on top of older workflows. And an example I'll give you about not so great usability. There was a quality metric in Meaningful Use Stage 1 called, was stroke treated appropriately? And the definition of the appropriately was TPA given, but only if the stroke occurred less than 2 hours ago. So we can say definitively, because I'm a doctor, that never before in history have I said, so Mrs. Smith, did your husband start acting funny 1 hour and 59 minutes ago or 2 hours and 1 minute ago? No such data element exists in any EHR, but yet a quality metric depended upon it. So what did the EHR vendors do? As soon as you start documenting a stroke, a little pop-up box appears. So how many minutes ago was this? Right in the middle of the workflow. And it's very disruptive and irritating, and it just makes the job of documentation ever so much harder. So that's just one example of where usability, just through no fault of the EHR vendors, but usability wasn't optimized. So you can imagine with 21st Century Cures and its comments on the enhancement of usability that we'll not only get electronic health record version revisions, but we might see an ecosystem of niche products, apps that layer on top of the existing DHR that give clinicians a much more pleasing way to document. See, my favorite idea would be, what if the patient and the doctor just had a conversation in front of Alexa, and then Alexa wrote up the chart for you? Now, I give you that as a fictitious example because we know there are all kinds of privacy and business associate agreement issues right now with doing that. But it illustrates the kind of usability we'd want to target, having the clinician burden of documentation substantially reduced. So you'll see that as probably an emphasis of ONC. It is very clear, and although Tom Price is no longer our Secretary of Health and Human Services, when he was our Secretary of Health and Human Services, he was very concerned about the burden that we have layered on top of the workday of our clinicians, not only the capture of electronic health record information, but the computation of quality indicators and lots of government reporting and security and privacy controls and patient and family engagement and ICD-10 and all these things happening simultaneously. So again, you'll probably see in ONC's agenda, how do we give clinicians more flexibility so that the overall burden of data entry and use of the electronic health record is diminished. And you can imagine that someday the electronic health record will be the friend of a clinician rather than the enemy that causes 50% of our doctors in the United States to want to resign today. So lots of work to do on reduction of burden. And I think you'll see this overall theme that regulation is unlikely to be the weapon of choice. That is, I think ONC is going to convene, ONC will advise, ONC will build incentives and industry alliances, but we know in the current administration that the executive order, so to speak, is if you're going to create a new regulation, eliminate 2 other regulations. So that's probably not going to mean thousands of pages of new regulation over the next couple of years. So Don is, as I say, a good person. He has good domain expertise, and this is likely to be his focus: interoperability, usability, reduction in burden, not use so much regulation, and really implement 21st century cures in a bipartisan way. What are some of the things we've seen over the last 90 days that you folks should know about? Because they do affect your IT planning and budgeting and your strategy. So remember, Meaningful Use Stage 3 was to take effect in 2018. So here we're going to have, January 1, 2018, everybody was going to have a 2015 certified EHR with all kinds of new capabilities and APIs, and you were going to have a new set of quality measures and going to be, quite extensive if you need to rip and replace inpatient and outpatient EHRs with something brand new with new workflows and new features by January 1 of 2018. So at the moment, Meaningful Use Stage 3 has been deferred to January 1, 2019. It is completely optional for 2018, and you will not need to upgrade your EHR from your 2014 edition or your 2014 quality measures to anything in 2018. You got a whole year to plan. And you could ask the question as you look at this list of stuff that I'm going to go through, January 1, 2019, will it be optional again? And that's a good question. So certainly we want to stay current with the releases coming out of your EHR vendor, but I think you do need to be a little careful given this amazing amount of deferrals and delays and decreases in regulation that maybe you want to weigh the risks of doing something versus the risks of not doing something, especially if you have competing priorities that your patients and your staff and your administration are asking you to fulfill. We know as well in the last 90 days there's been a reduction in any reporting requirement for meaningful use or for the and that's for eligible professionals, or for the inpatient quality reporting program. And so there was to be, even with the revisions that I just described about where Stage 3 is delayed, there still was going to be a year-long reporting period in 2018. And now that year-long reporting period has been converted to 90 days. So again, in your planning, if you want to get a meaningful use 2015 certified edition up by January of 2019, think about it. You only have a 90-day reporting period here. Maybe, there are certain delays in your project planning. Use the last 90 days of 2018 to get things upgraded, or use the last 90 days of 2018 to do your quality reports for 2018. That 90-day window gives you some flexibility in your planning. It's much easier than having a whole year. We talked about quality measures, and quality measure computation has been time-intensive and burdensome, but there are going to be fewer quality measures required currently for the electronic quality measure program, for the inpatient quality reporting program, and for the meaningful use program. There's a substantial reduction, only 4 for inpatient and 6 for ambulatory or the eligible professional meaningful use quality measures. So reduction in burden and complexity. And then we know that certification has been a very painful exercise for many of our vendors. Hundreds of man-years in some circumstances to get through the certification process of very complex, comprehensive software systems. So ONC announced on September 21st that it would be reducing the burden of certification by now requiring fewer test procedures. And in fact, with this self-declaring by the vendor of compliance with 30 of the 55 test procedures, followed by what will be industry surveillance to make sure you told the truth. And having been through the certification program, I can tell you a whole lot of the certification criteria were things that were not really value added, like can you type in an allergy and come back a day later and make sure the allergy is still there? Do you really need to certify that? I think the marketplace would absolutely tell us if allergy recording didn't work. So one would hope that as the certification program continues to evolve, it's more going to be about do certain interoperability functions actually exist and perform as specified. Because that's, in my view, the whole certification program overstepped what it should have been and created way too much administrative overhead and burden for all. It should have focused very narrowly on successful interoperability. Some early thoughts on the federal government role. Now, we've been talking about ONC, and that Don Rucker would largely not probably focus a lot on regulation, but I think what you're seeing overall is that both CMS and ONC and all the HHS departments are really thinking about what do they do to chip away at existent regulations, defer them, and delay them. And in fact, we'll see how far this goes. But yesterday, Anthony, I don't know if you guys published an article on this where the Medicare Payment Advisory Commission actually recommend that the merit-based payment system under MACRA be eliminated. Wow. We've all been spending the last year to two focusing on MACRA and MIPS and preparing for this new world of a different kind of reimbursement. And in issuing its comments, this Federal Advisory Commission said the burden on clinicians of MIPS is so high, it will cost $1 billion just in direct physician time to comply, and therefore it should probably be deferred, delayed, removed. So going to be a lot of debate about that. And when you look at ONC's budget, currently the House approved a 37% reduction in ONC's budget, and your Senate is keeping it flat. But likely what it suggests is that the scope of activities of ONC will be substantially reduced because the funding will be substantially reduced. So I think you can start to see this trend here. Less regulation, less direct government agenda making, smaller footprints, less ONC, which means the private sector is going to have an increasingly important role. A couple of other things. As the private sector innovates, we're going to see more and more mobile apps, more home health, more Internet of Things, telehealth, these sorts of things. And a question comes to mind, well, will the FDA regulate these? And the FDA is increasingly clear that it is only going to use a risk-based framework to regulate, and that if there are wellness or administrative apps, things that help you eat less, exercise more, you're not going to regulate that stuff. And so you're going to see with the next couple of months, I think, some further clarification of this. But what I'm hearing is, sure, if you create an app that is attached to your body and is measuring body parameters in such a way that a diagnostic or therapeutic decision could be made that could cause you harm, there will be some regulation. But mostly, the private sector will be given the freedom to innovate without a lot of FDA involvement. I also reflect with Tom Price's departure that that is going to cause a slowing of change and momentum. And so that's just every time a secretary, a cabinet member departs, that's going to cause an interruption in the cadence. What I hope is that the federal government still will have an important role in doing things like rationalizing privacy policy across our 50 states, in helping us determine a nationwide patient matching strategy so that we can take records across state lines and commingle them and figure out from a care management perspective where are the gaps in care. You hope the government takes a role in maybe a provider directory so we know how to reach clinicians electronically for the exchange of information. And so the government can be convener and catalyst, if not regulator. So give the private sector opportunities to innovate, but still have an important role to raise such issues and to convene meetings. In that spirit, where do I think the private sector is going to go? What are some of these technologies that we need to watch? Well, increasingly we're seeing ways of delivering data to patients themselves. And yes, not every patient is going to want to be the steward of their own data, but maybe the patients are going to be able to designate a third party, a relative, or a service to curate their data on their behalf. This idea of sending data about you to you after you complete a clinician visit has been very successful at Beth Israel Deaconess with our Open Notes initiative and our mobile apps BIDMC at home. And so I just see patients and families finding much more value in apps that show you care plans, variations from care plans, to-do items, alerts, reminders, and really bring you into a shared medical record as an equal participant and not just running some separate PHR portal. So I think there's just this whole suite of technologies around that to watch. And remember, Epic just announced Share Everywhere, where a patient can give one-time access to any care provider in the country so that that Epic record can be viewed with patient consent. Increasingly, as we see fast healthcare interoperability resources and FHIR mature a bit and new transactions made available in production systems, Cerner, Epic, Meditech, Athena, etc., I think there's going to be a new generation of what I'll call decision support service providers. This is not an EHR function, but imagine there's a cloud-hosted entity that can provide you important information on a care plan or a new drug trial or an intervention for a patient who has symptoms similar to other patients. And that is called by your EHR and a pleasing result provided back inside the EHR workflow. So the FHIR team has recently published a specification called the Clinical Decision Support Hooks specification, which enables exactly this kind of thing. Data from an EHR goes to a cloud-hosted decision support service provider and is returned with a set of care plans or recommendations or a genomic analysis or evidence or clinical trial or whatever. So I think we're going to see more of that. And I hear more and more companies engineering those kinds of solutions. As well, the FHIR team has come up with a bidirectional scheduling API So think of open table for EHRs. That today it's really hard to write an app that interacts with an EHR for scheduling availability. Yes, you can schedule a haircut, but you can't schedule a doctor visit. That's sort of the nature of the way that EHRs, as a bit of data silos in the scheduling era, have been to integrate. So with a bidirectional scheduling API, you'll see the emergence of really interesting mobile solutions looking for doctor availability and helping you get the care you need. And lest I sound too much like the Gartner hype curve, and I have included a Gartner hype curve just for reference in my next slide, really machine learning is starting to get there. And I don't mean that doctors are going to be retiring soon or radiologists will be eliminated, although some say such a thing is true. I mean that machine learning techniques are helping us sift through the mounds of data we collect and look for variance, look for patterns, help us eliminate a lot of rote manual tasks. An example from Beth Israel Deaconess, we get 18 inches of paper every day that humans have to read. We've been using machine learning techniques, specifically Amazon Machine Learning Services, to read that paper for us, extract metadata, figure out where it needs to go, and 99.9% of the time, get it done without a single human taking a look at it. So those things, they're becoming mature. And we are increasingly now getting daily data from bathroom scales and blood pressure cuffs and other kinds of home monitors and integrating that into EHR workflow. So those things that were initially speculative at this point, and especially as we head into 2018, there are real products and services to watch. And this is just an example of some of the things that we are doing with emerging private companies in self-development, focusing on machine learning and analytics, mobile solutions, and workplace productivity, more like a Facebook for healthcare and social networking interactions of care teams and groupware communications and mechanisms of optimizing workflow and OR times and doing all of this from phones and tablets. So lots of exciting stuff. It isn't science fiction. It's not flying cars. These are real solutions that we've been deploying. And so as I said, let's just reflect together in my final minute on looking at that Gartner hype curve. Now remember, the Gartner hype curve starts off with the introduction of a technology, then peaks at the area of the inflated expectations, the pinnacle, and then you move off of that into the trough of disillusionment, up the slope of enlightenment, and eventually get to the plateau of productivity where certain products and services are real and actually fit for purpose. So when you look at this, and what you see are things like, yeah, you know, I'm hearing a lot about machine learning and AI and blockchain and these sorts of things. Yeah, okay, those are a little overhyped right now. But there are going to be real use cases, as we have started to find, as long as you focus yourself on the things those technologies do well. I will be working on a blockchain application in Africa with a really specific use case. Today in Africa, an average HIV patient gets CD4 counts measured 7 times a year because no one can track their data. And so the narrow application, which a nonprofit foundation has asked me to work on, is can we simply, in a public ledger with appropriate security controls, track HIV test results and make them available to the patient on their phone when they go to a visit. And so the technology is blockchain and GSM cell phones, and that's all. So there's an example. Okay, maybe if that's your use case, a public ledger for tracking certain results available to a patient in a secure fashion, maybe that's going to be a workable solution. So just take a look at the hype curve. Be aware that every technology has a life cycle, and we just need to be very careful to separate fantasy from practicality. And these technologies I've talked to you about today, with the emergent use of machine learning and the Internet of Things, some early specific use cases on blockchain are becoming real. So that's where we are. And so, Anthony, why don't we turn it back to you, and then, of course, look forward to Q&A.
Excellent. Very good. All right. Thank you so much. Yes, looking forward to the Q&A. Now we're going to hear from our sponsor, represented by Lorna Green. Lorna, thanks so much for joining us today.
Thanks so much for having me. I always get to enjoy getting to be part of these every quarter. And since I was with y'all in June, Hyland Software has acquired Perceptive Software Business Units, which is an exciting time for us. So in addition to what we've traditionally had as our ECM product, OnBase, we now have incorporated into our solution AccuO, Millread, PaxGear, and also Brainware. So as a result of that, we have a new Hyland Healthcare vision. And our healthcare vision is that we would bring you content and image management so that you can have your clinical, financial, and operational needs in your healthcare world met better. We want to empower you, inform, and simplify. And this always has been our philosophy at OnBase and Hyland, is that we want to make everything accessible through your EHR. We know that is your main core operating system. That's where your physicians, clinicians, nurses, doctors, ancillaries need to and want to work. But we also want to make sure that all data can be brought there in one place for your clinicians to work on. Because right now we know there's a lot of different disparate systems around in our different organizations, and we want to help bring data to the hands and eyes of your clinicians. We want to be able to use methods like XDS to share content, and we want to integrate content in any way we can. And we feel like VNA is a key database platform for the future. And I just quickly want to go through what, well, let me go back to that because I forgot to say the words that were important here, is the Enterprise Information Platform, the EIP. Don't we love all our different acronyms in healthcare? But we at OnBase are now going to help you develop your healthcare enterprise information platform. And what that means is we want to help you use OnBase and enterprise imaging capabilities, which now are under our umbrella, to capture, manage, access, and exchange your data so that your data will be optimized as your clinicians go to treat their patients. And this is just another visual showing that we have Hyland and our enterprise, Hyland OnBase, enterprise imaging together want to feed into your EHR so that your clinicians can get a full total picture of the patient. So just as a recap, we now at Hyland Software, under our umbrella, is the DNA named AccuO. We also have PaxGear, which is another video touch MDR component, and we are working on mobile integration of PaxGear. And we also now have the Millread viewer, which will integrate with our OnBase patient window. So with these new products, our enterprise imaging products, we want to combine them with traditional capabilities of enterprise content management and give your clinicians the tools they need to see all the data in your organization. So our motto now is that we're one company with unlimited possibilities. And if you happen to be a customer that owns one of those pieces of software and hadn't heard this message yet or aren't sure what it means to us or to you as an organization, my email is on the first slide of this presentation, and feel free to reach out to me and I'll get you connected to the right person in the company to give you the information that you need to understand where we go from here. So thank you, Anthony, so much.
Thank you, Lorna, and just put up your first slide there so you can grab Lorna's email and phone number. And she's about the friendliest person you're ever going to meet, right, Lorna? So give her a call.
Please do.
Very good. Very good. All right. Thank you, Lorna, and thanks so much to OnBase by Hyland for sponsoring these events and helping get this great information out there. So we're ready for our Q&A. I have some questions in. Go ahead and keep sending them in the Q&A box. Leave the default set to all panelists. So Dr. Halamka, first question, wouldn't it make more sense to see ONC focus on coordinating the many HIT investments across the many departments inside the government to meet the needs of the current administration?
And this is really a brilliant observation. So what does ONC stand for? The Office of the National Coordinator. And so, as you suggest, wouldn't it be a great idea to have a single front door for all federal government activities? And so ONC could be that coordinator for DOD and VA, and for FDA and FCC and FTC and all these other folks who may touch the healthcare system. I think the interesting question is, I mean, I know Don extremely well, and I know his staff extremely well, and I know what they can do with their limited resources and budget. It's not so much just administration. I just think that Washington is a huge place with many stakeholders and what I'll call 1,000 points of veto. So I would love to see ONC do what you say. I just think it practically may be somewhat difficult. So keep that thought.
Keep that thought. Very good. Next question. When do you think FHIR will become the preferred message type that will displace the traditional HL7 message types? Okay,
well, that's a loaded question because the answer is never.
Okay.
Why never? Because FHIR is a totally different approach. So HL7v2, what does that do? I register a person and then I send a message to another downstream system saying the person just registered, or I send a lab result from place to place or an order from place to place. We'll actually need that kind of pushing of data forever. So HL7v2 and its refinements, I think, will stay around forever. Where FHIR is useful is in query response. The patient just showed up in the emergency department. I need to go query their data. Or what's their immunization status? Or, has this patient ever had an opioid prescribed before? FHIR is really good at that kind of thing. So think of APIs powering an ecosystem of apps that are doing get and puts from EHRs as opposed to V2, which is more the plumbing that is necessary to coordinate moving parts in a push fashion. So they're very complementary and will coexist.
And so give me a little explanation of where blockchain fits with those two.
Well, okay, so what is, oh my God, this is so hard. Right, so what is blockchain? Right, blockchain is simply a public ledger. It's nothing that magic. It basically gives me a ledger that is tamper-proof so that I can say, in the case of Bitcoin, Anthony gave me 1,000 Bitcoin. Here, look at the ledger. And by the way, Anthony has never done that. And so imagine that if you're going to use blockchain as a component of an infrastructure, a public ledger, that building some mechanism for an EHR to get and put data from blockchain might make sense. Again, it's going to be a very limited use case. Let's not overpromise or over-exaggerate what blockchain can do today. But here is an example, Anthony. What if we were worried about the integrity of your medical record, that it had been tampered with, that it had been altered? Well, what if there was a FHIR API from an EHR to blockchain, and all that happened when an EHR record was signed, that a hash of your record was sent over the FHIR API to the blockchain so that at any time in the future, we could re-examine that hash and say, oh, yeah, this record has not been altered. It's, in effect, just a way of proving the integrity of data. So these are the kinds of narrow use cases we need to think about.
And that could be useful for looking up sort of a incidental or a nefarious change. So if you go into the wrong record, we talk about all the patient matching problems. Someone goes into the wrong record, thinks they're in the right record, makes a change. The blockchain may allow people to go back and sort of figure out what happened when.
Or I have been involved in many cases in my career where there is an assertion that in a malpractice claim that the record was altered. And it's really hard from an IT perspective to prove that a record was never touched. Right? And you say, oh, we got audit trails. Oh, well, the audit trails, they were corrupted too.
Right.
But if you had this blockchain idea that especially in a malpractice assertion, you could guarantee the integrity of the record.
Okay, very good. Let's talk a little bit about use cases as it pertains to government initiatives. You keep talking about the importance of having use cases. Can you give me an example of something that sort of run amok because there was no specific use case, just a general idea that this would be good to do?
Well, sure. So in the case of, we've been talking about patient matching, right? And if what you say is that in the meaningful use program, you must compute quality measures across multiple disparate organizations for the purposes of tracking whether something was done or not done, and every single organization matches patient data differently, what you end up with is chaos. So I'm not asking that we issue a single national healthcare identifier at birth, although many other countries have done that, and it does work for them. But if we have a nationwide patient matching strategy, and we say, okay, guys, when you go to compute quality measures or you go to consolidate records or reconcile medications, this is the strategy you use, then we will bring much more repeatable results to the process.
Very good. Next audience question. I think this relates to what you're talking about, the EHR certification, and that the market will provide feedback on whether or not something's missing. So the question is, wouldn't the randomized surveillance put more onus on providers and organizations?
That's a fascinating question, which is all of us have participated in things like the Joint Commission, right? And the Joint Commission, they're great people, and they do a very valuable service. But what usually happens in a hospital before a Joint Commission visit is you study for the test, right? So that is, you expect you're going to be asked certain questions, and you're prepared for those certain questions, and you have all the artifacts and documentation. So when then the surveyors show up, you say, here you go. As opposed to real-time user feedback on social media. And I'm not suggesting that social media be used to evaluate EHR efficacy, but I just wonder that are tales from the trenches from clinicians who are using this going to be a bit more potent. And it's just my experience in the recent Department of Justice settlement with eClinicalWorks, that all came about because of clinicians who were not able to use certain functions that were supposed to be in the product as part of certification.
So the questioner has a point, though. It does put the onus on the end user to collect information, take action, and there'll be a few bucks in it for whoever does it sometimes. So there's an incentive
so
there.
In the case, well, yeah, so, I think both approaches have their merits, but of course, comment that I heard around the Department of Justice settlement with eClinicalWorks is the person who reported it received $30 million. Now, Anthony, can you find $30 million of flaws in your EHR? I know I'd like to try.
Yeah, very good. All right, blockchain-related question from the audience. What kinds of things can providers start doing to prepare for implementing blockchain technology in their organizations?
I think the most important thing to do right now is just understand what it is and what it isn't. And so there's a lot of articles about blockchain. I wrote a review for the Harvard Business Review, and I'll send that to you, Anthony, and you can circulate it, just telling you what the use cases might be, what it can do, what it can't do. So right now, blockchain doesn't scale. How many transactions can blockchain, say Ethereum, do per second? 7. It's a computationally very heavy and intensive process, but there are newer technologies that are more scalable that are evolving, and the one that I'll be working with in Africa is one that in theory should be able to deal with millions of transactions. So just be aware. understand its strengths and weaknesses. So when you hear a story about blockchain, you'll be able to decide, that doesn't sound right.
Right. All right, just as a final question, and we don't want to get political here, we try and stay away from that, but your general feelings on the direction of HIT policy. It sounds like, just from listening to you every quarter, that you thought we sort of have overreached from a policy point of view, and too many things people have to do and not leaving enough time for innovation and for people to practice medicine, and perhaps we're getting a bit away from that. So your overall feeling on the direction of policy and how our listeners and CIOs should feel about sort of the next 6 months, the next 3 months.
Right, so absolutely. And so 2 weeks ago I wrote an article for the New England Journal, which I will also send to you, which is exactly reflecting on this question, which is you have to give the government a lot of credit that it took an industry that was largely paper-based and made it digital in record time. And to do that, it had to overstep. And it had to, in some ways, co-opt the agenda. And we get it. And so I give them credit. But now let's reflect on the lessons we can learn from that. We've disenfranchised our clinicians. We've given patients 5 portals. We've not achieved the layers of interoperability we want. So as we go forward to now solve and address those gaps, I just think we're going to be in a period of time where the market innovation with, some government catalysts and some government convening can be more powerful than more regulation. And that's what the New England Journal article reflects on.
Very good, very good. Well, I will send those links to those articles out. Perhaps I'll do it on Twitter using the hashtag HSCIOchat, so people who can easily find it. And we appreciate that, Dr. Halamka. We appreciate your participation as always. Well, that's about all we had time for today. When you close out your window, you're going to be taken to a post-event survey. If you could take a moment to answer that, we'd appreciate it. For those of you with continuing education interest, attending our events gets you 1 CEU towards the CHIME CHCIO certification program. So let CHIME know you were here, and if you've asked us to do so, we will. For those of you who need a certificate of attendance for another CEU program, you can use the final slide in this deck. You'll receive an email when our archive recording of this event has been posted to our YouTube channel. If you'd like us to produce a webinar on the topic of your choice, you can contact Nancy Wilcox, and you can go to our website to view our upcoming webinar schedule. So with that, I want to thank our speakers, Dr. John Halamka and Lorna Green from OnBase by Hyland. I want to thank OnBase by Hyland for continually sponsoring these events, and I want to thank all of you, our attendees, for supporting us. Everybody, have a wonderful day. Thank you.
Thank you.